long-term follow-up more than 2 years and to compare with intra-articular injections in rheumatoid elbow. It is held in AIMS. The study is held in AIMS. First introduction, as we know, rheumatoid arthritis is chronic systemic inflammatory disorder affecting around 1% of the world population, in which synovitis is the hallmark, typical involving the joints of hand, wrist and feet, and later on the large joint of the body, in which the wrist is the most common involved site, which considered 87%, followed by shoulder, knees, and ankle and elbow. Our concern in elbow joint in rheumatoid arthritis. So the involvement in elbow, it is around 20-25% within the 5 years of the onset of disease, and the definite involvement within 15 years of the disease onset is around 66%. Morbidity and mortality with non-means of the life expectancy, shortening by the 7 years in the male and 3 years in the female. Then the treatment options. Addition to the NSAIDs and the other anti-inflammatory drug, DMRDs, disease-modified anti-rheumatic drug, are the mainstay of treatment, which we offer every patient from the rheumatology department. Then the use of biologicals like anti-TNF agents, which are very famous in the outside of India, but due to the endemic disease and the immunity status, these are very restricted in India because of the flare of tuberculosis and the endemic infections. Then other options are arthroscopic synovectomy and the intra-articular injections, which we consider, which relieve pain and the gain function with when optimal drug treatment fails. Then the open synovectomy. In this study, we compare the intra-articular injection and the arthrosynovectomy, which is they are not studied in the past. The purpose study, or study purpose mainly is there is a very few study dealing with the arthrosynovectomy for the effectiveness of elbow arthrosynovectomy, and those studies which are there, they are very short-term results, not the long-term results. For the study, we have to start the study for the long-term results, but due to some clinical reasons, we did not proceed this study because of the person and the patient's problems. Then the aims and objective. We evaluate and compare the effect of the arthroscopic synovectomy with that of intra-articular injection in the rheumatoid elbow. The material methods. The study design in the single center case control study, with patient given the option to choose a treatment. So it is not a RCT or random match control study. The study venue is AIMS Department of Orthopedic and Medicine, Rheumatology, and the sample size are 30 elbow. Actually, we include the 30 elbow. We study around 55 elbows, and we included 15 elbow in the arthrosynovectomy group and the 15 elbow in intra-articular injection group. Then inclusion criteria. Actually, the study was started in the rheumatology department first. So the criteria was old, which is American College of Rheumatology 1987 revised criteria. The additional to it, patient with the 2 or more clinical diagnoses for synovitis, they are included. Pain, swelling, and the stiffness of joint affecting the daily activity of the patient are also included. And then the non-responder to the optimal DMRD and the radiologic changes not more than the Larsen grade 3, which Larsen grade 3 I will discuss later on. The exclusion criteria was that if there is an history of trauma, any sequelae of arthritis or infective arthritis, then gross deformity of the elbow, which is hinder the manipulating and the intervention of the elbow, and the severe radiological destruction like Larsen grade 4 and 5, and the previous history of the elbow surgery in any kind of surgery, and the flexion of elbow less than 90 degree. That means arc of flexion is not a flexion. Arc of flexion is less than 90 degree. The parameters measured are, there are the 6 parameters which we measured for the subsequent interval like 0, 1, 6, 24 and 30 months. These are the visual analog score for pain, Myo elbow performance score for the function ability of the elbow, then the X-ray score, X-ray modified Larsen's grading, and the coronoid height ratio. Then the disease activity score, which is mainly rheumatology department, and the range of movement. The age. These are the p-values of the pre-operative patients, which shows that these both groups are comparative and comparable, and treatment for the treatment evaluation, these are good cohort groups. These are finding that the vision analog score between the two groups. There is from the 0 months, there is almost equal score for the both arthroscopy and injectable group. In this 0 month study, then it will fall steep in the arthroscopy group. At the 1 month and 6 months, actually they're equal. It is very good improvement in the pain relief and movement, and then it almost equal plateau stage up to 6 to 24 months and slight decline in the 24-month follow-up, 4 or 24 follow-up. But in injection group, it was improved in the 0 to 6 months, but there was slight deterioration toward the 6 to 24 month and 30 month. Then the MAP score is the My Alpha Performance Score. It is equal to that the VAS score, and it actually includes the 4 parameters: that the pain, stability of joints, functional ability of the elbow, and the functional ability of the elbow, stability, pain, and the range of movement. 4 parameters. In the pre-operative period, there is an injection group with the red, indicated red. It was slightly more than the arthroscopy group, but it will deteriorate with the time at the 30 months. But it will improve in the arthroscopy group 0 to 6 months and up to the 24 months. Deteriorated towards 30 months, but it maintained around 80% improvement up to 30 months and forward. Then the Larson grading, it is a radiological grading, so it is not improved or deteriorated with the time. Or almost it is at the 0 month it was 2.46 in the both group, and the 30 month it was 2.5 in the both group. So it was not much more affected by the treatment by any kind. Then the disease activity score is a very complicated score which is helped by the rheumatology clinic, and it is a compound of the tender joint, swollen joint, and the ASI-CRP value with VAS score. And it is affected by 28 joints basically, so we only approach one joint, elbow. So it is not affected mostly because there is a DMRD treatment and other physiologic therapy. So it is affected by 28 joints, so there is no more changes like 6.48 to 5.97 in the arthroscopy group and 6.47 to the 6.29. But there are results in the arthroscopy group better. Then the coronoid head ratio, it is ratio about from the coronoid articular surface, oligurine articular surface to the tip of the oligurine coronoid from the ulna base of the and the tip of the. It is a ratio of the X-ray finding which determines with progression of a ratio deteriorate the disease. There is the at the arthroscopy group there is 0 months for 49.5 and the injection 51.69. But it is not affected much more by the treatment plan, so there is no better outcome. The range of movement, it is very good parameter which is which we observed in the OPD also, that at the 0 month there is 67.6 point mean value at the arthroscopy group, which is improved further up to 85, and the injection group it is 84, and it is deteriorated to the 72.3.7. But at the 1 month and 6 months there is obviously improvement in the apparent improvement in the study, but it will deteriorate with the injection treatment but improve with the arthroscopy group. In the conclusion of our study, there is a 5 or 6 conclusion which are included, that the short-term results were very good in both the groups, and the better results were observed in the younger active patients than older patients. Then the patients undergoing regular follow-up under the rheumatology clinic and the physiotherapy clinic, which we included in the AIMS, with orthopedic treatment, were seen to have better outcome, because we did that intervention, but if the patient not taking the proper treatment and physiotherapy, it was not very beneficial. And patient undergoing early intervention, mean duration of the disease, have an improved outcome, and the patient undergoing surgery like arthroscopy synovitis, our interest area, had better outcome as compared to the injection group. These are the conclusion. Then the limitation of our study, there as the patient were given the choice of treatment, either conservative or surgical. So it was not a randomized control trial, because due to the Indian population, we can't force the patient to do any study and ethical issues. So we invite the patient for any treatment like conservative surgical. Then the sample size is very small in both the group, 15 patients, and drugs are different with different patients according to the clinical picture. This is determined by the rheumatology doctors. This confound factor are not included in the study, and the follow-up was only for 30 months. Then it is not considered long-term follow-up, because my study was only for 30 months, and a longer follow-up can reveal a different pattern of disease status. Then there is no similar study like intra-articular injection versus the arthrosynovectomy, so that no similar study in the literature of comparison. So we can't compare the study from the other kind of issue. We can only compare the synovectomy with the synovectomy, arthroscopy or open. But there is no injection group study in the past which compare the other parameters. Thank you.
Thank you, Dr. Pankaj. Is there any question from the house? You know, I just want to ask one thing that
Yes, sir.
as arthroscopy surgeon, I myself see so many cases. What was the extent of effusion and synovitis that you decided to, patient can't decide.
Yes, sir.
You said the patient was given a choice. But what was the extent of that synovial thickening and synovitis that you decided to go for synovectomy? Because I don't think that you can go for synovectomy in every case.
Yes, sir.
It's not that much.
So actually, patient follow up of the rheumatology clinic. They sent to for the consultation to the department, and by the MRI finding. Actually, I have not included MRI findings. MRI finding and the symptoms of patient. The patient can do the work, or patient wants better outcome, or he wants to do normal work with routine work. कि मैं कर सकता हूँ काम में. I don't want to change the work, my work, daily living work. Like young active patient, I told young active patient who wants to be involved in actively the works, daily works. We offer that to orthoscopy. मतलब थोड़ा बहुत बोला कि we can improve, but it is not clinically and MRI basic findings, not the.
Anyway, but I think that rheumatology people do so many things. But as arthroscopist, you have to decide whether going into the joint will be able to do something good or not. It's
Yes,
not
sir.
neither patient's choice nor rheumatology people's choice. They don't know anything about real arthroscopy.
Yes, sir.
So
So
that
actually
I
you-
feel that was the main thing you should have considered in your study. Rest of the things it's okay.
Actually 6 parameters we do the radio conference and other things.
Anyway, thank you very much.
Thank you, sir.
So please stick to your time. And Dr. Akshay Gandhi, is he here? So please come and present your prospective randomized control study of effectiveness of viscosupplementation, Highland GF20.
Good morning everyone. I, Dr. Akshay Gandhi from Manipal University, present your prospective randomized control study studying the effectiveness of viscosupplementation following arthroscopic debridement in patients with symptomatic osteoarthritis of the knee. There is a big debate in the literature regarding the effectiveness of viscosupplementation and arthroscopic debridement in the treatment plan of osteoarthritis knee. Few studies done in the past, like in 1993, 2003, 2006, they have showed that viscosupplementation and few studies regarding arthroscopic debridement that it is effective in the treatment plan of knee osteoarthritis. A study done in 2012 by Annie et al. Have suggested that viscosupplementation is not effective in knee osteoarthritis. There is no randomized control study comparing between the non-operative treatment and arthroscopic debridement with viscosupplementation in knee osteoarthritis. So we did a prospective randomized control study to study the effectiveness of arthroscopic debridement followed by viscosupplementation in selected patients with knee osteoarthritis. Our study included 123 patients with a mean age of 55 years with Kelloggen-Lawrence grading grade 1, 2 and 3 with VAS score 4 or more, and in the arthroscopic subset with outer bridge grading as grade 1, 2 and 3. Patients having gross deformity like varus or valgus deformity were excluded from the study. In the arthroscopic subset, patients who had grade 4 outer bridge classification cartilage lesion or who were diagnosed as inflammatory arthritis by biopsy and who underwent marrow stimulation were excluded from the study. 123 patients were divided into 3 groups, 41 each. In the first group, patients underwent non-operative treatment in the form of bracing, medication and physiotherapy. In the second group, 41 patients underwent arthroscopic debridement using the standard 3 arthroscopic portals. In the third group, patients underwent arthroscopic debridement followed by viscosupplementation at an interval of 3 weeks. Arthroscopic debridement was done using the standard 3 arthroscopic portals. Basic viewing was done. Arthroscopic surgery consisted of synovial shaving, biopsy, plica excision adhesiolysis, osteophyte excision, loose body removal, abrogation chondroplasty and microdebridement using coagulation. Patients were evaluated using the VAS score and the WOMAC score preoperatively at 3 weeks, at 6 weeks, 12 weeks, 6 months and 12 months. The results in the 3 groups, non-operative group, arthroscopic debridement group and arthroscopic debridement with viscosupplementation group were compared. Better pain relief was seen after arthroscopic debridement, but sustained pain relief was seen in arthroscopic debridement followed by viscosupplementation group. Following viscosupplementation, patient satisfaction and WOMAC score improved significantly in comparison with the no injection group, that is the other 2 groups. Concomitant analgesic usage was significantly reduced in the viscosupplementation group. Dependency on the medication was seen in the non-operative group. There was a significant improvement in the pain, stiffness and function assessed by the WOMAC score A, B and C in the viscosupplemented group. I conclude that viscosupplementation following arthroscopic debridement is an effective treatment option for the selected patients with knee osteoarthritis. The beneficial effects of arthroscopic debridement were prolonged following additional viscosupplementation. Thank you.
Thank you, Dr. Akshay. Any question from the house?
Yeah. Good talk, but I think you should have included one more arm where only viscosupplementation should have been included, because it was just a suggestion. You could have taken another group where only viscosupplementation.
Only viscosupplement. Yeah, we have compared with that also, but we have found a better result in arthroscopic debridement with viscosupplementation group. But here we are presenting with, as there was no comparison with arthroscopic debridement and viscosupplementation and non-operative treatment, so we are presenting this prospective randomized control study.
And whether you have found any adverse reaction for viscosupplementation?
Sir, the patients for 48 hours after the viscosupplementation, they were told to avoid the strenuous activities, but as such, no, the patients only had, some patients had pain, which is a very common side effect after viscosupplementation, but otherwise no sepsis or anything adverse effect was seen after the viscosupplementation.
May I ask one question? So you used a similar brand in all patients?
Yes,
Probably
sir. Hylan
which one?
GF20.
No one comes by this name. It's Invest
No,
1 that is originally
Yes,
this
sir.
is. So kindly let me know that you randomly selected from grade 1 to grade 3 in your groups. So how can you justify arthroscopic debridement in grade 1 arthritic patients if you have selected in your group? Do you think grade 1 arthritis is meant
Sir,
for
actually
debridement?
arthroscopic debridement and viscosupplementation, they are more effective in the selected patients like with low grade OA and the patients who had mechanical symptoms. So we included grade 1, 2 and 3 in our inclusion criteria because low grade OA, and grade 4 was excluded from the study.
Grade 4 is out of question, we all know it. But I am just asking, in a grade 1 patient you selected in your group 3 for arthroscopic debridement and so viscosupplementation. So how one can justify?
So they were randomized, sir. After, the patients were randomized who will undergo.
You can't go beyond ethics in your randomization. In grade 1 arthritis, who will say that you can go for arthroscopic debridement in grade 1? That's the thing I want to emphasize, because you can't go beyond ethics in your randomization. So please take care from the next time.
Okay.
I hope so.
You can include
With the permission of
grade
the
1
chair.
arthritis with
With
some
the permission of the chair, I am the guide for this thesis.
Okay. Please.
Grade 1. The primary concern here is not the grade 1, 2 or 3. The concern here is a mechanical symptoms being present for the patient. Patient with grade 1 also can have a very significant mechanical symptom. That was the selection criteria for arthroscopy. That was not the only criteria. Grade 1 is not the only criteria. I agree fully with your point that grade 1 alone you cannot put the scope into the joint. I agree with you fully. But grade 1 with significant mechanical symptoms, they were included in the study.
But
You
in
say
our
mechanical symptoms like meniscal tear,
Yes, yes.
but you cannot find out them in prior MRI, that this is primarily scoped for meniscal tear, not for the
Even if it
arthritis.
is MRI diagnosed, it is still in the study.
no,
Because
as a
in-
guide, you can support your study. I'm not saying anything, but anywhere in the world, it's difficult to justify arthroscopic lavage and debridement for a grade 1.
Arthroscopic debridement is recommended even by insurance companies, even by AOS,
For grade 1 OA.
AANA, grade 1 with mechanical symptoms, you are justified in doing arthroscopy.
Okay, then you have worked out in good detail. But
Because,
otherwise,
and about the ethical committee, we have an institutional ethical committee
Yeah.
which prevented us from doing the randomization for the other two groups. The
my
group-
suggestion was that if you have included only grade 2 and 3, that would have been more
It's,
ethical
in
and good.
osteoarthrosis, if you go through the literature, you'll realize that it's very difficult to go by one criteria, either X-ray criteria or by arthroscopic criteria. You'll have to go by ultimately the patient's subjective complaint, that's a pain is a complaint, and mechanical symptoms are the complaints. So I think you get the point. So grade 1 being not the only criteria for selection.
Anyway, thank
Mechanical
you.
symptoms take a higher precedence over the grading.
Okay, okay.
Any other questions from the floor? Thank you.
Thank you, sir.
Dr. Gandhi.
So now Dr. Atul Bandi, are you here? Yeah. So you go ahead with your paper on role of platelet-rich plasma in arthroscopic rotator cuff repair.
This one? Good morning, everyone. I'll be speaking on role of platelet-rich plasma in arthroscopic rotator cuff repair. As you all know, rotator cuff injury is one of the commonest cause of pain around the shoulder joint. Degenerative and traumatic, the main causes for the same. And patient presents with the pain and weakness with multiple tests positive for the shoulder joint. The three most diagnostic tests of high value are painful arc, drop arm sign, and weakness in external rotation. X-rays in AP, axillary and outlet view can be taken, and ultrasound is also a good diagnostic criteria with more than 90% sensitivity and specificity, and MRI is the gold standard. The treatment can be given in the form of conservative by modification of activity, physiotherapy, pain medications, or subacromial subdeltoid injections of corticosteroid or hyaluronate. And surgery as a mini open repair or a arthroscopic repair can be done. The shortcomings of the surgery are there could be problem of, after the repair of cuff to footprint, that is in tendon to bone healing. Failure rates as minimum as 11% to 94% has been recorded in the literature, and the cause is due to poor vascularity, aging, altering tendon quality, nicotine, smoking, and pre-op steroid injection, and even NSAIDs have been reported as the cause for same. Microfracture of the footprint, Crimson Dewey technique, biological augmentation using PRP, stem cells, extracellular matrix, and low intensity pulsed ultrasound or nitroglycerin. I'll be talking main on the platelet rich plasma, which has a high concentration of platelets in it, and it releases multiple growth factors as TGF beta, FGF, PDGF, VEGF, and connective tissue growth factors, and EGF, along with some cytokines. The objective of aims and objective of the study was to investigate healing and vascular response of rotator cuff and to assess for significant difference in the functional outcome. It was a prospective randomized controlled double-blind study. The patients undergoing arthroscopic rotator cuff repair were taken and they were screened for eligibility and were randomized and included in the study. The time period was from November 2011 to May 2012. 54 patients were screened and 42 were eligible and randomized. 38 completed the follow-up and 4 were lost in the follow-up. The inclusion criteria for the study was if the patient had a full thickness rotator cuff tear proven on ultrasound or MRI, age 35 to 75 years, informed consent was taken from all.
a pre-op platelet count of more than 1,50,000 and a hemoglobin of more than 11 grams, and they had no disease that may limit the follow-up. Exclusion criteria consist of associated subscapularis tear because it may interfere with the post-operative protocol, a partial rotator cuff tear, active infection, osteomyelitis or sepsis, or distant infections which may spread, osteomalacia or other metabolic disorders, and if the patient was a chronic smoker. The PRP was formed in our blood bank from 30 ml of anticoagulated blood which was taken a day before the surgery, and it was centrifuged at 1500 rpm for 12 minutes. 10 ml of PRP was formed consisting of an average 1.5 times the platelet concentration, activated by 2 ml of calcium chloride consisting of 12 ml of activated PRP, which was injected over the repair site after arthroscopic repair. The needle was placed under arthroscopic supervision and 10 minutes were given for the settlement of the same. Intraoperatively, the single surgeon was doing all the surgeries by a single row repair. No other augmentation technique like microfracture was used. A subacromial decompression was done as and when needed, and PRP injection in subacromial space was put under supervision. Post-operatively, no NSAIDs were given to the patient. A standard rehabilitation protocol was followed for all, and follow-up assessment at clinical at 1, 3, 6 and 12 months by VAS, UCLA, constant Morley, assess and ward scores were done, and a USG follow-up at 3, 6 and 12 months was done. This was the arthroscopic setup. The needle was placed under arthroscopic guidance, and the needle as seen by the arthroscope, and the PRP was injected to the same over the repaired site. The demographic data was insignificant in all accounts in the PRP and control group. PRP had 20 patients and control group had 18 patients. The VAS score, there was a significant difference at 1, 3 and 6 months. Although both are showing a significant drop in the scores, PRP and control group, but there was a difference of at 1, 3 and 6 months with the PRP group showing better results. And at 3 and 6 months, the significant difference was seen in SF12. And in UCLA scores at 6 months significant difference was seen. There was no significant difference seen in constant Morley, assess and ward scores. In the ultrasound examination, re-tear and vascularity was seen with ultrasound was seen at peribursal, peritendinous, myotendinous, intratendinous, pericortical and suture anchor sites with the vascularity, and the vascularity at more than 2 of these sites was significant at 3 and 6 months, and it was at 3 months vascularity was shown to be significant in all 6 sites. At 6 months it was seen to be significant at 4 of these sites, and at 12 months, although there was no significant difference seen, yet higher vascularity was seen in the PRP group. The re-tear rate was lower in the PRP group, and at 12 months there was no re-tear rate seen, but these numbers were insignificant. Epidemiological factors, there was no significant relationship as seen to with respect to age, gender, BMI, dominant height sign, and although more rates of re-tear was found in diabetic and elderly patients, but it was insignificant. Other studies in the international publications has been showing positive and not positive results with after using PRP for rotator cuff repair. The conclusion of my study was PRP accelerates functional recovery, PRP increases local vascularity and thus probably accelerates healing. Small and medium sized tears show better results with PRP augmentation, quicker healing tendency and lesser re-tear rates. Large to massive tears have increased tendency to fail and re-tear following repair surgery, and PRP has shown to decrease this re-tear rate. Older age and diabetes has increased prevalence. PRP has shown a positive results in them also. The final conclusion was physiological amounts of platelets prepared by inexpensive methods stimulate healing at the repair sites as compared to expensive commercial systems claiming to have many times higher concentration of platelets. Hence, use of PRP has shown a beneficial effect towards the rotator cuff healing for Indian population and should be employed wherever feasible. Thank you.
Thank you, Dr. Atul. And it was a good paper, and I think it needs more trials to prove the things.
So the thing is, this was at the time of May when we had completed by around 38 patients. We continued this study till November and we have taken 62 patients. And in that it has shown even better results in constant Morley and work score at 12 months.
But the thing is that if you are producing this kind of cheaper platelets from the blood bank,
Yes,
and
sir.
you are putting them, there is no harm in
Yes, sir.
trying certain things. Although there's a much difference from a degenerative type of tear as compared with the traumatic one in the
Yes, sir.
players.
Yes, sir.
At the age range from 35 to 75, it's a very wide range. At a person at 75 and a person at 35, they have inherent difference in their healing rate.
Yes, sir.
So-
So the average range of this study, average age of this study was 56 years, and in the older patients, we saw that there were more tears in the older patients and more re-tear chances also post-operatively. But PRP has shown, in the PRP group, it has shown to decrease those re-tear rates. later on.
I think should keep on increasing the numbers of this study,
Yes,
so
sir.
we have better idea. Any question from the house?
Yeah. Two questions. One is in the conclusion slide where you said attributed everything of the platelet-rich plasma, that it decreases, it accelerates healing and all.
Yes.
But based on the scoring you have done, how can you actually extrapolate it into that? You should rather tell the scores decreased, but there was not much significant difference.
Sir.
What was the difference? Because the graphs were almost similar.
Yes, sir.
So was it to catch such a small difference? Did you find it very significant? What was
Yes,
the
sir.
p-value?
So the p-value was less than 0.05,
Okay.
and I shown the significant difference in VAS scores, UCLA scores, and one more, it was assess scores, SF12 scores that I have shown.
Okay.
These were the functional, clinical and functional scores, and even increased in vascularity at the repaired site.
How
So,
did you
yes,
find?
sir.
Did you do any test to find it out?
Yes, sir. Vascularity was seen by a power Doppler ultrasound technique. I've shown the slides also in the same.
And
So
the second is the PRP you use one and a half times concentrated.
Yeah, the PRP, that platelet-rich plasma concentration that we had made was in our blood bank only, and the concentration that we got, the PRP, we calculated it out the platelet count, and the count that was coming was compared to the original platelet count of the blood of the patient.
Got it.
So it was 1.5 times around, like if we take out the mean of the same.
By definition, if you want to label it as PRP, it should be at least 3 times concentrated.
No, sir. There is a classification for the same. It is called as PAW classification. In that, it is categorized into 4 types. So it comes into moderate quantity. The type 1 is less than 1 time the blood concentration. The type 2 is 1 to 4 times the blood concentration. So it is the moderate type in which it comes.
Thank you.
What is the studies are equivocal on the both sides,
Yes, sir.
in favor and against. What is the most important finding you have found in the PRP group, that these patients are doing better in terms of healing, pain, another thing in short-term follow-up?
So VAS score, they have told that pain is significantly different.
For short-term?
For short term, immediately short term, like within 1 to 3 months, we'll come to know that patient is complaining of less pain as compared to what he was having before. But the clinical and functional outcome and even the re-tear rates, which is the most important thing, because otherwise patient might come again after 1 year or 2 years for the tear of the rotator cuff. That has also been shown to decrease, sir.
The study you have quoted from Italy, the Milan
Yes, sir. I have quoted number of studies, sir. Randelli,
Randelli
Castellani.
studies,
Yes, sir.
that shows that there's no significant difference except the pain in the short-term follow-up.
Yes, sir.
I mean, in the shoulder workshop that we attended yesterday, Dr. Okhari mentioned that he was using PRP for non-operative cases, and that the pain actually increases over 3-4 days drastically, and you have to inform the patient regarding that by using PRP.
Yes, sir.
And according to your study,
Sir, I have not calculated immediately following giving the injection, because there we are doing an operative procedure. The patient will even complain of the operative pain, and there is a lot of swelling following the surgery also. So we have not calculated the immediate following it. We have calculated after 1 month. The first follow-up was at 1 month.
The possible explanation for any injection therapy, PRP is given for tendinopathies and various other healing patterns as well. Probably any injection therapy increases the pain immediately. Yeah, either it is hyaluronic acid or anything. So probably that is the possible explanation for immediate increase in pain. But in a week's time, that pain subsides and goes back.
So, thank you, Dr. Atul.
Thank you, sir.
And Dr. Sandeep, you are here. Please come and for your presentation, the treatment with, what is this? Platelet-rich plasma and more effective than placebo for knee OA.
Very good morning to all of you, respected chairperson and my dear fellow orthopedic surgeons.
My topic is treatment with platelet-rich plasma is more effective than placebo for knee osteoarthritis in a prospective double-blind randomized controlled trial. The aims and objectives were to evaluate the efficacy of intra-articular injection of platelet-rich plasma as a treatment modality for early OA, and to evaluate the safety profile of PRP injection in knee joint osteoarthritis, and also to study the relation, if there is any, and also to quantify the dose required of the PRP for intra-articular injection to achieve a therapeutic efficacy. We studied in December 2010 after a proper written informed consent, and the sample size was calculated based on an assumed study power of 80%, which a false positive rate of 5%, with the alpha being 0.05 and a predicted difference of 1.5 points on VAS score. And using these parameters and adjusting for multiple corrections, we got approximately 21 patients per treatment arm. A total of 75 patients in age group between 35 to 70 with grade 1, 2 or 3, some 3 early osteoarthritis knees as per Albeck's radiologic staging were included and were randomly divided into 3 groups. This is the chart where after assessment we divided into 3 groups, and the group A we had 54 knees, that is 27 patients, and they received a single injection of PRP. Group B received 2 injections of PRP at a space of 3 weeks apart, and the group C was a control arm. The baseline characteristics were confirmed, and the p-value, there was no significant difference between all the 3 groups in comparison, which means that randomization has affected. 100 ml of whole blood was taken and was transformed into a sterile plastic tubes, and after centrifugation in a 2-stage soft spin and a hard spin, we had a platelet-rich plasma. What we additionally added was we included a leucofilter so that we can take off the leukocytes from the platelets, and we gave a leukocyte-free PRP. And the final product, we added 2 ml of calcium chloride for every 8 ml of PRP. That was initially calculated based on study how much is required to coagulate the required, activate the required amount of PRP. And we used a specific supralateral pole of patella in all the patients. We immobilized it for 5 minutes till we achieved the clots, and then we kept them under observation for 2 to 3 hours. Ours is Mishra type 4B because it's a leukocyte free and with counts more than 4 times concentration. We followed up the patients at 6 weeks, 3 months and 6 months, the main criteria being a WOMAC score, and also we at every follow-up we check for any adverse events. At 3rd month again for WOMAC score, and at the 6 months we also evaluated for VAS for pain in addition, and whether they were satisfied with the procedure. Results: a statistically significant improvement in all WOMAC parameters were noted in group A and B, beginning at an average of 2 to 3 weeks, but with a slight tendency of worsening at the 3rd follow-up. At each follow-up, the percentage benefit from baseline was greater in group A and B compared to C, that is C was the control, which was a normal saline. Albeck's grade 1 knees fared better than grade 2 knees, and when you compared group A and B, that is single injection of PRP in comparison with 2 double injection of PRP at 3 weeks apart, there was no much difference between both the groups in terms of clinical improvement. These are the graphs which depicts, this is the WOMAC pain, this is stiffness, physical function, and the total WOMAC score. We can see in the control arm there is no change in mean pain score. However, in both group A and B, there was a dip in the total mean pain score the first follow-up, and then however at the last follow-up there was a slight increase in the pain, but from the baseline there was still benefit persisting at the end of 6 months in terms of all parameters. There was no difference between both the groups A and B, almost similar. There was no statistically significant difference, and Albeck's grade 1 knee fared better than grade 2 knees. At each follow-up, the percentage benefit from baseline was greater in A and B, which we can see. This is the baseline 0, and this is where the most of the values fell, that is there was a benefit, and in group C there was no benefit. This is the first follow-up, 2nd and 3rd. And the VAS score also decreased in group A and B from 4.5 and 4.64 to 2.3 and 2.10, but in group C it was almost the same, control arm. In our cases we noted some adverse effects. They were mild, nausea, sweating, headache. They were immediate and occurred within 30 minutes. in 6 patients out of 27 in group A and 11 of 25 in group B, and again 5 of 25 in group B at the second injection experience, but they were mild and not much of a problem. Mild complement, systemic nature and short duration. The discussion, the problem in PRP studies is a lack of standardization of study protocols, the platelet suppression techniques and uniform outcome measures. There is also lack of evidence to support the clinical use of PRP and other autologous blood concentrate as well in most of the orthopedic problems. Some of the unique feature of our study was it was the first randomized control trial in PRP. Just a minute, sir. We have used a specified supralateral portal. We used a specific formulation of PRP, that is Mishra's type 4B. We compared with placebo for the first time. We used normal saline. We as well compared a single injection group with a double injection group. There was a definitive correlation with Albrecht's grade A doing better than grade B. This is almost same findings compared to Kohn et al., who noticed better results in degenerative chondropathy compared to early osteoarthritis of the knee. The second, even his trend of the study was at 12 months there was a slight worsening of the symptoms. We were also able to get a standardized leukocyte free, that is type 4B. The number of platelets injected was an approximately 2.5 billion in comparison with 6.5 million used by Kohn et al., almost 400 times higher. One feature unique was the documentation of some adverse effects, but they were nothing to worry about. Role, basically in people tell that there is chondral remodeling occurring because it alters the basic anabolism, it favors anabolism and decreases catabolism, and chondral remodeling has been postulated to be a cause of benefit. Anita et al. Said in PRP it has got a group, it is a complete mixture in a right concentration which can influence it in a positive way, and chondral remodelism. But the question is actually chondral remodeling the cause? Because some certain things we noted was, if chondral remodeling was the cause, the effect for the procedure would have taken much more time. The mean duration of stat of benefit was 17.63 days in group A and 16.45 days in group B. Also therapeutic benefit, at the third follow-up, there was a slight dip in the benefits. If chondral remodeling was the cause of improvement of symptoms, we feel the benefit would have started much later and probably would have lasted for a much longer duration. So this gives rise to a next good research question. Now we can study if one injection is as effective as two. That was our next study, because single injection group and two injection was similar, and the improvement deteriorates over a time. How about considering it this way? We give a single injection now, after 6 months or 10 months, once the patient has pain again, then go for a second injection. So this is a good focus for future research. So conclusion, PRP in a single dose is a safe treatment modality for symptomatic relief. Single injection is as effective as double injection. Improvement of symptoms was noted by 2 to 3 weeks, which gradually improve over 3 months. However, there was a slight worsening of symptoms at third follow-up. Mild adverse reactions were noted. This was published in American Journal of Sports Medicine. Ever wondered how a wound heals? We feel the power of healing lies within us. Thank you.
A nice presentation. Any questions from the floor?
Do you think this injection of PRP is a definitive therapeutic modality, or it's just to postpone TKR or something like that?
Definitely, it's not a definitive modality as such, because that's what we are working on. People say it's chondral remodeling, but definitely WOMAC scores clinically patients have improved. It's just another option for us to give relief to the patient in a more biological way.
And what is the advantage do you think this has over intraarticular hyaluronate injections?
It's biological.
Biological. Okay. And what is the cost of this if it is outside?
The cost, there then comes issues. To be very frank, PRP is not, according to all the rules and regulations of in India, it's not marketed for public use asset. It still lies in a research question. Only if you have proper clearance under ethics committee, under that coverage you can do it. And again, there are two types. Basically, what we did was we prepared our own through a blood bank. Otherwise, we get filters where it actually costs up to 20,000, which is available outside.
Yeah, Dr. Acharya, you want to ask something?
I just want to commend this speaker and the previous speaker for highlighting the effectiveness of indigenously prepared PRP over commercially hyped up PRPs. They cost less than 1,000 rupees and they are as effective, proven scientifically now. I just want to commend them on that.
Thank you, sir. Thank you.
So, thank you, Dr. Patel. I think your study has yet to reach a conclusion.
Yes.
Right now, there's practically no answer what it is doing. So, thank you very much.
Thank you, sir.
Now, Dr. Gaurav, you are here. Please go ahead with your presentation. It is fixation of tibial avulsion fractures of the PCL by a minimally invasive posterior approach.
Respected Chairperson, my dear friends, very good morning to all. Avulsion fractures of the PCL are not uncommon injury nowadays, considering high motor vehicle accidents and increased interest in sporting activities of our Indian population. Most common injury mechanism is a dashboard type injury with a blow to the anterior aspect of the knee with the knee in flex position. The undisplaced ones can be treated simply by immobilization in a cylinder cast with an anterior pull on the tibia. In the displaced ones, there is a general consensus that surgical reduction and fixation in the acute phase is the gold standard. In the past, such fractures have been dealt with a classic posterior approach involving a very large S-shaped curvilinear incision. It involves a lot of surgical dissection and increased surgical time. There is exposure of the neurovascular bundle, and thus there is a risk to the injury to the popliteal vessels and the nerves. And due to the dissection of the sometimes involved in the gastrocnemius muscle medial head and the poplitis, there is loss of the function of the secondary stabilizers of posterior laxity. So these injuries were very often neglected due to such approach. Now, Roger Barrett in France described this technique, which was a minimally invasive posterior approach in the techniques of knee surgery, which involved inverted L-shaped incision over the posterior aspect of the knee, and it involved limited soft tissue dissection and adequate visualization of the posterior aspect of the knee. It was based on anatomical dissections done in 20 cadaver knees, where he found that the level of the tibial insertion of the PCL actually corresponds with the level of the head of the fibula, and when you project this point on the skin, it actually lies halfway over the line at the level of the head of the fibula. So as with all MIS approaches, the prerequisite is very accurate positioning and of the patient as well as of the skin incision, and precise knowledge of the anatomy and correct sequence of the surgical steps. 3 or 4 deep Langenbeck retractors are required, and there should be a good adequate focused light source in the OT. This is an example of a 2-month-old PCL avulsion injury which was displaced along with a sciatic nerve injury of the same side. The MRI showed a displaced PCL bony fragment with an intact PCL. This was the posterior sag, and the examination under anesthesia showed a grade 3 posterior drawer test. The patient is placed in the prone position with the leg is draped free so as to flex the knee at will. Initially, to start with, the bolster is placed under the foot so as to keep the knee in a slightly flexed position. We mark the flexion crease and the level of the head of the fibula with the help of a C-arm. The intersection of the medial hamstrings with the flexion crease is marked, and the incision actually starts just lateral to the intersection of the medial hamstrings with the flexion crease. There is a horizontal arm laterally about 3 to 4 centimeters, and then a vertical arm which lies about 1 centimeter medial to the skin projection of the PCL on the tibia. So the skin incision inverted L-shaped. After incising the subcutaneous fascia, the medial head of the gastrocnemius is exposed. Here is the intersection of the hamstrings with the medial of the gastrocnemius. Now there are 2 approaches where we can reach the deep capsule. Either we can retract the whole medial side of the gastrocnemius, but the authors here described actually splitting the medial head of the gastrocnemius at the level of medial 1/3 and lateral 2/3, which allows for easy retraction of this bulky head of the muscle. So here is after retraction of the muscle, the posterior capsule is exposed, and placement of these retractors in medial, lateral and inferior is very important. Then the posterior capsule is split, and we expose the posterior aspect of the knee joint. This is the medial femoral condyle and the posterior aspect of the tibial articular surface. With blunt dissection with the help of a finger, the avulsed fragment can be separated, and it can be fixed with a canceller screw, either cannulated or non-cannulated with washer.
This was an old injury, so I could not actually reposition it anatomically, but still I could achieve the tension in the PCL. After confirming the position of the screw under the C-arm, the incision is closed in layers. Post-operatively, the patient is placed in a rigid long knee brace with a bolster under the upper calf so as to pull an anterior tug over the tibia for 2 weeks. The active straight SLR and isometric quadriceps are started from the next day. The patient is mobilized after 2 weeks of stitch removal in a prone position with passive knee flexion, and full range of motion exercises of the knee are started after 6 weeks. Full weight bearing is started at 3 months. This is the same patient with a follow-up at 5 months showing a good union of the fragment and a healed scar. The 3 months there was loss of the the anterior tibial step-off was maintained, and he had a good posterior drawer. A negative posterior drawer, sorry. So I've done 15 cases between 2008 and 12. Most of them were males. Most of them were acute injuries, although I could extend my indication beyond 1 month. All were done by MIS, and most of them were screw fixations. These are some of the examples. A large fragment fixed with 2 screws. Again, posterior drawer, which became negative after the approach. This was another female patient with a large piece. Two screws were put. And this was a combined injury with a posterior cruciate ligament avulsion with a lateral complex injury fixed with bony anchor and a screw. Another case. So as with all approaches, this also has some problems, and the problem that I faced was the marginal necrosis of the skin at the angle because of the significant retraction involved. These were 2 cases which healed by secondary intention. So what I have modified this is that I normally now curve the incision a little bit and avoid taking sharp corners. So it is important to remember that always keep the knee in a slightly flexed position so as to aid in the exposure and keep the neurovascular bundle separate. And also always ensure correct placement of the retractors, check the placement regularly by the assistants, and also allow some period of relaxation in between so as to avoid marginal necrosis. Thank you for your attention.
So, any question? Dr. Arun, you are doing a lot of PCLs. You should comment on this presentation. Okay, sorry.
Was there any case in which you started with the minimally invasive and had to extend the approach?
No. Initially, I took about 1 to 1.5 hours, and with time, actually, the time has gone down now approximately to about 30 minutes or so.
Okay.
But none of the case I had to resort to an open classic approach.
Do you think would that be necessary to extend in any case of anatomical variation for larger fragments?
You can very easily separate the whole fragment.
Regarding the skin incision, the vertical limb of the incision is perpendicular to the Langer's line, and as you have demonstrated on 2 of your cases, so that has got a tendency to form a keloid or hypertrophic scar because they are perpendicular to the skin line. So that is one wise thing, that you have modified it made it more curvilinear rather than L shape, and it's a good technique to fix it in acute phase. Because the anatomy is clear, there is a God-given plane to separate it and feel the fragment. And it's a good crossover technique from wide posterior arthrotomy to all total arthroscopic fixation. So it's a good crossover technique. You can graduate over to arthroscopic technique over a period of time while you are fixing that. Any other question from the floor?
I'm Dr. Vijay. Sir, you said 3 months of partial weight bearing after in the post-operative period. Is it necessary, or is it 6 weeks or 2 months? Is okay. So you have any previous papers or scientific data regarding that?
There have been papers which actually do not allow full weight bearing till the time of union. So I thought it is better to be a little on the more conservative side. So although, I mean, most of our Indian patients, even if we tell them to put weight on the limb, they'll say, okay, we'll wait for some time. So I think I try to be more conservative.
If you've got a good anterior cortical purchase from your cancellous screw, probably you can allow weight bearing at tolerance. You can feel that the fixation, how solid is the fixation. At times the fragment is comminuted. So you are not very sure whether what I have done with the screw is quite sure. It's good fixation, it can reavulse if the patient wears weight in early phase. So if it's a solitary chunk and it is fixing like this, interdigitating with the fracture defect, with the screw, it has got a rotational stability. Probably at the time of suture removal, you can allow the patient to wear with brace or something like that. How? At the time of suture removal, that is 2 weeks time. That's a very vascular area, it heals very fast. When you take most of the patient, when you take X-ray at the 1 month interval, if it is fixed anatomically, you won't find any fracture line there.
I've not seen any screw backing out, I mean, in all the cases.
Initially, everyone is a bit conservative that everything should go properly, but when you gain confidence, you can allow them. Many of the patients come to your outdoor walking themselves.
Yeah.
They just say, Doctor, bas abhi aapke yahan hi chalaunga, ghar mein nahi chalta hu. So that gives you a clue that you can allow them weight bear early.
Thank you, Dr. Gaurav.
Thank you, sir.
And Dr. Mukul, you are here. So please go ahead with your presentation on ACL reconstruction using 4-strand hamstring graft.